All right, so far we touched upon treatment for stage 4, stage 3. What about stage 2B and 2C in the adjuvant setting? And my question is, what's your opinion on this? Do you routinely put patient on this adjuvant? What's the risk and reward benefit?
Very important question. Okay, so first of all, we have a couple of trials that were presented this year for the patients with stage 2B and 2C. These are no negative, but still relatively high risk melanoma cases.
Sure. Yeah.
And it was shown that with either, pembrolizumab or nivolumab for a year, the risk of relapse significantly decreased, right? So it works regardless of the stage. So that we know. But the issue is we know there's a significant risk for toxicity, even with single agent anti-PD-1.
Yeah.
We know that some of those toxicities, many of them are transient, right? Like they happen, we can treat with steroids and then they go away. But about 15 to 20% of these toxicities are what we call these endocrinopathies. These are side effects that affect the hormone glands of the body, the thyroid gland, the pituitary gland. These are like the hormone producing glands of the body. And when those get affected, it almost never comes back. And so these are permanent side effects. And if that happens, patients have to be placed on lifelong hormone replacement therapy, basically, right? So lifelong thyroid, hormone replacement, whatever. So there's, that's an important downside, I think. So if you have a 30-year-old
downside, yeah.
2B melanoma that very well may be cured by surgery alone, do we treat, right? With the knowledge that will reduce the risk of relapse, right? But we don't have the data that treating now in the adjuvant setting is any better or any worse than waiting to see if, God forbid, it recurs. Let's treat then, still with the goal of cure.
Yeah, right? Yeah. Hopefully by then, let's say, if God forbid this recur 5-7 years down the road, you may have some newer therapy that has better clinical efficacies.